Welcome everyone to this special edition of our Jefferson Otolaryngology Grand Rounds. Today we welcome you to a symposium basically on anosmia, a sense of hope. This is a special symposium presentation in advance of Anosmia Awareness Day, which is this Friday. During this day, we try to increase awareness in terms of anosmia and the difficulty it causes for many individuals across our country. And we also try to highlight today some of the causes of anosmia and perhaps some potential cures. Anosmia is the clinical term that describes the complete loss of sense of smell. And what we really are bringing attention to is the loss of function, but not only the loss of function, but the loss of pleasure and all these other very intimate moments that disappear when the sense of smell vanishes. Part of our program and part of our goal with our partnership with the Monell Chemosensory Institute is to raise awareness and to really make people realize that this is indeed a problem. What are the patient care goals of our program? Well, today we want to talk a little bit about what patients perceive to be the problem, because they not only lose their sense of smell, they also lose their sense of taste. And so they ask, how can I lose both my sense of smell and my taste? And they want to know, what's the cause of my smell and taste problem? More importantly, they want to know, am I likely to recover? And how can I cope with this loss? And finally, when they come to you as a physician, they really want to know, what can you do to help me? So these are some of the issues that we're going to discuss today. We want to, as we said, increase awareness and knowledge about the frequency and causes of anosmia and the lack of treatments, and increase awareness really of the new research that's being done at the Monell Chemosensory Institute and also here at Jefferson to find better treatments. So let me introduce the folks on the panel briefly. I'm Edmund Pribitkin here at Jefferson and studying smell for over 20 years with my clinical colleague Beverly Cowart Dr. Cowart from the Monell Chemosensory Institute. Dr. Mira Vinjamuri, also a researcher at the Monell Chemosensory Institute, and Dr. Kai Zhao with us as well today from Monell. So, are there really that many people that suffer from a loss of smell and taste, Beverly?
Actually not, and mainly because there are not very many people who actually lose their taste. What happens is that although at the periphery, smell and gustation are completely different physiological systems, they both respond to chemical stimuli in the oral cavity. And there is, in the brain, considerable overlap in the cortical areas they project to. And most notably, there's a lot of secondary smell projections to the primary gustatory cortex. And probably as a result of that, all flavor sensations tend to be interpreted by people as coming from their mouth, and so they think they've lost their taste. So this is just a little schematic showing orthonasal smell and retronasal smell. On the other hand, a lot of people lose their smell, either partially or completely. There have been estimated to be 6 million people who suffer from complete anosmia and millions more from partial loss or hyposmia, with the most common causes being ongoing nasal sinus disease, prior upper respiratory infection, and that can just be a regular common cold, can produce a long-term smell loss, and closed head injuries.
Well, Beverly, we understand then that it's a problem, and we do see patients come through the office that talk about their smell loss. Can you tell us a little bit then about how does the sense of smell work?
So the primary olfactory neuroepithelium is located fairly high in the nasal cavity, primarily around the superior turbinate, although there is some neural tissue that extends down to the superior portion of the middle turbinate. This neuroepithelium is composed of millions of olfactory receptor neurons, which are actually primary brain neurons, except that the cell bodies are out of the brain. They're vulnerable for a couple of reasons. One is that each of these neurons extends the ciliated dendrite into the nasal cavity, and that's where the smell receptors are located. So you've actually got nerve cells interacting directly with the environment, which is a very unusual situation. And as a result, they're vulnerable to damage from all the junk that we breathe in and out. In addition, they each extend an axon that connects directly to the olfactory bulb in the brain, but to get there, it has to go through the cribriform plate, which, as I'm sure most of you are aware, is kind of like a honeycomb. But because of that positioning of these fine neural fibers in that bone, when there is head injury, the coup contre coup forces can crush or sever those nerves, and that can also cause smell loss. Now, the one sort of positive thing about the olfactory system, which Mira will be talking about more, is that these neurons are also unusual in that they regenerate throughout the lifespan. And within the neural epithelium, you'll see various stages of growth and degeneration, starting with a basal cell that can commit at some point to either becoming a new olfactory neuron or a supporting cell. Cells that are committed to become neurons but haven't quite made their dendrite and axonal connections, mature cells, and dying cells. And as I said, that process seems to go on throughout the life cycle, but it's never perfect, and it probably becomes much less efficient with age.
So, it's really an amazing system because you really have primary neurons that are essentially first-order neurons that are exposed to the environment. And because of that, you have these dangers that can occur to those neurons, and you have neuroolfactory loss. But, when someone comes into the office and they're just basically saying, I can't smell things anymore, how do we quantify that? How should the primary care physician or the otolaryngologist really establish that they have lost their sense of smell, Beverly?
So the two primary measures that are used clinically are odor identification and or threshold assessment, which is just simply measuring the minimum detectable concentration of some substance. In most clinical practice, what makes sense, obviously, is some commercially available form of these kinds of tests. The two probably best known are the smell identification test, marketed by Sensonics, and the Burkhardt sniffing sticks, which is used extensively in Europe, marketed by Medisense. However, these can be relatively expensive for a clinician, particularly if he's not testing a whole lot of patients. And there is now another option, relatively new alternative, which is an odor identification test that was actually developed by Monell scientists and other scientists for the NIH toolbox. So this is available through NIH. The actual cards with the odors on them are available through a company called Prenascent. For as little, an order as small as 100, which will last a couple of years actually, you can get these for $4 a test. And they have a number of advantages. One, they've been normed down to 3 years of age. And we can do this with 3-year-olds because you have the option not of giving word options saying what it is, but just pointing to the correct source of the smell. And these are the various items that are used for identification.
It's wonderful that kids still recognize the smell of Play-Doh. I think that's something that everybody remembers from their childhood. Beverly hasn't mentioned it, but the truth is that this child version of the smell identification test was actually begun here at Jefferson and Monell in conjunction with our partners at Nemours DuPont, where we actually published one of the first verified testing solutions in terms of really looking at children and showing that, yes, they can be tested down to the age of 3 in order to really establish whether or not they have or haven't lost their sense of smell. It's fortunate that the adult versions are different from the child versions, not something that we want to necessarily give 3-year-olds coffee and and cigarettes, but something that perhaps they are exposed to as well, unfortunately. In terms of the types of smell loss, there are really two ways of looking at the question. One is transport loss, that is, smells can't get in. And so we see that with nasal sinus disease, we see that particularly with nasal polyposis, but we also see changes in the neuroepithelium with even chronic rhinosinusitis. Some of the work done at Monell and other centers shows that the neuroepithelium is going to become more disjointed in patients with chronic rhinosinusitis. Moreover, the recovery from any injuries to the sense of smell is somewhat blunted in patients that have these types of difficulties as well. The other type of loss that we look at is sensory neural loss, and that quite simply is that the nerves don't work or the nerves can't transmit the information to the brain. And this occurs most commonly with upper respiratory or viral infections. And some have suggested that that's actually a defense mechanism. Teleologically, perhaps, if a bad virus infects the nose, it can travel up the nerves and infect the brain. Rather than let that happen, the first-order neurons die off and prevent that kind of travel up into the central nervous system. Closed head injuries, as Beverly mentioned, also can be a source of smell loss because those nerves are severed at the level of the cribriform plate. And then we do have quite a number of patients that come to see us where we really don't know what has caused their loss of sense of smell. So the question is, when we're looking at conductive losses, that first type, the transport losses, how do odors actually get up to the neuroepithelium? What constitutes a normal airflow to that area? And actually, you would think that's sort of a simple thing, but the flow dynamics are actually very, very complex. And this is something that Dr. Zhao has studied here at Monell.
Oh, yes, Ed. I think it's widely acknowledged in the field that there's a potential of blockage of flow that contributing to olfactory losses. There's even notion of conductive olfactory losses, like you mentioned, and neurological olfactory losses, similar to what define hearing, conductive and versus neurological hearing loss. And but as Ed was mentioning, that actually there's little physical examination available that you can really reliably, objectively differentiate if there is a conductive olfactory losses. For example, there's polyposis is often a very strong predictor of olfactory impairment. Polyps, is indication of severe obstruction, but also indication of very severe inflammation. So it can go both ways. And there are studies that are looking into a standard rhinometric measurement, such as rhinomanometry and acute rhinometry, to measure nasal resistance and airway cross-section areas. There's a lot of studies going on, and the correlation to olfactory losses is actually poor or very inconsistent. So that's presenting a very strong clinical problem. And also the surgery, sinus surgery, you guys have expertise in it. Then remove the obstruction can often improve olfactory function, but there are recent outcome studies showing that this improvement is sometimes variable and very difficult to predict. So that's why we enter this field by looking at how we can, through engineering approach, to modeling this airflow and nasal airway, and you can see here is a series of CT scan from the tip of the nose to the back. This is probably not intention for you, but for general audience to look at how complicated the nasal airway in the human is. And this model we is showing here is actually based on exactly the CT scan of each individual. So it can capture whatever airway obstruction potentially in this subject. And this two nostril in the front and the olfactory cleft is really in the top for people that don't know about that. So let's look at what can we simulate the transport of it. So this is this is a natural breathing condition. You're releasing some odor particles in the nostril, and track. You're using computation model based on very individualized CT scan. You can see where it goes, and this is olfactory region. So some eventually reach the olfactory region, but majority of them doesn't. So even in healthy cases, there's a very small percentage, roughly 15% of the airflow that actually gets to the olfactory region. And this is the trajectory. So if you link all the trajectory of these particles, you see this path line of the flow field. So this is on the left side of this subject, which is very convoluted. You have swelling, and there's swelling up here in the olfactory region. And this is the right side of the same subject. And you can see here is the flow is quite laminar, and here is olfactory region. So the point I'm trying to make is that the airflow in the nose is quite sensitive to some of the regional changes. And we actually show that the reason this left side of this same subject has a little bit swelling of flow and the vortex is due to a very narrow obstruction right here in the nasal valve region. And if you can see here, where's the point? Oops. Okay. If you we have tried artificially remove the obstruction, then the flow will become as smooth as the right side. So this will be an indication that, even though this obstruction is far away from the olfactory region, there could potentially be a ripple effect that causes flow pattern changes downstream. And we follow up with slightly more extensive clinical studies. We look at 29 patients. We construct for each one of them individual nasal cavity model, and we can simulate the transport of odor to the olfactory epithelium. And this is showing that this is measured carbon, one of the odor detection thresholds, and this is prediction of the carbon detection thresholds based on simulation and 3 other factors. So it's made a good prediction of the olfactory losses in these patients, differential of olfactory sensitivity in the patients. So in summary, our modeling study seemed to confirm that is a conductive impact of olfactory functions, and more so that we can use this computation model to better pinpoint if a blockage that's contributing to a patient olfactory losses. So you can design a better surgical plan for a better surgical outcome. By the way, when I mean we, I is actually a team of Monell and Jefferson scientists who are clinicians and involved in the study. Both Ed and Beverly are part of this study. They are both co-authors, and we are we've been planning an ongoing clinical study, and hopefully by some time in the future we can give you more examples or more solid evidence how we can better improve the conductive aspect of olfactory function. Thank you, Ed.
So, it's fascinating because at first, when we think of smell loss, we think really the nasal polyp patient. This is the patient where you have large polyps obstructing the olfactory cleft, and it's quite clear that they've lost function. But what we've shown through some of Kai's work and work done in other universities is that actually, because so little of the flow actually gets up to that area, reductions in that flow can really cause drops in the sense of your sense of smell. We're talking here not only about smell identification, because that's one aspect of smell loss, but we're also talking about thresholds. So that is that some of us can detect odors at a much lower threshold than others. What happens with age is that there's sometimes a gradual diminution of function. And some of it is a diminution of the ability to sense specific odors, but some of it is also a change in threshold. And we've studied some of those changes here at Monell. And the question is, if you have someone presenting to you that has a gradual loss of smell rather than an acute loss of smell, is that something to take into consideration in a different way, Beverly? Is that something that we have to be more concerned about other problems?
Well, the main, as you mentioned, there is a tendency for people to lose their sense of smell with age. But on top of that, smell loss is a very early indicator of a number of neurodegenerative diseases, most notably Alzheimer's and Parkinson's. So sometimes you can detect smell losses before other symptoms occur. More generally, there have been some recent population-based studies that have shown that olfactory loss is a very strong indicator, particularly in people over 70, of 5-year all-cause mortality. And it's independent of many other factors that play into all-cause mortality. And the thought is that there are two possible explanations. One is that it's a sign of poor regenerative capacity in general, because the olfactory system relies so heavily on regeneration. And secondly, it may be a sign of lifelong toxin exposure, which would tend to impact the olfactory epithelium. So it can, it's not a good thing to lose your sense of smell.
Yeah, I think, the gradual losses, the question always is, for gradual losses, do you obtain imaging studies? And there have been a number of meta-analyses in the literature that look at this. And basically, certainly if there is something in the history that suggests a neurodegenerative disease or a family history that suggests such an event, that you should look at obtaining an imaging study. And then the question is what type of imaging study to get. If you're looking at conductive losses, as Kai has suggested, the CT scan of the sinuses is what is generally appropriate. Because if we're going to treat conductive losses, generally what we'll do is we'll use the CT scan to plan those types of treatments. On the other hand, if you're looking at neurodegenerative diseases, then an MRI scan of the brain is what's indicated. There you can see early signs of Parkinson's and you can see early signs of Alzheimer's. So we've looked so far at the ways that smell loss happen, the association of smell loss and flavor. We've looked at conductive losses. We can talk a little bit about sensory neural losses themselves. How do these acute losses occur? And you do have situations where you have traumas, where you have clear evidence of someone in a motor vehicle accident or someone has fallen and struck the back or the front of their head, and then they have an associated loss. Interestingly, that loss isn't always immediate, but sometimes what happens is there's a contusion or an injury that plays out over the course of 2 weeks or so before people really notice the loss. On the other hand, what we more commonly see is the patient that presents to us who has a cold. And during the cold, they notice that they're stuffy and they can't smell very well. And they say, well, I'm stuffy. I can't really smell because I'm just all blocked up. But then the cold goes away. And a week or 2 weeks later, they notice that, gee, my sense of smell has not come back. And that is typically when they present to the primary care physician. And unfortunately, most primary care physicians will basically just say, wait, it'll probably come back, or they'll poo-poo it and take the blood pressure, and they'll look and focus on other more serious problems. And this is something that we'd really like to change as part of our anosmia awareness program. Because what we'd really like to do is for the primary care physician to take a more detailed history to figure out if indeed the person has sustained a loss of sense of smell, and then refer appropriately so that we can evaluate the patients. One of the greatest difficulties that we've had in the 25-year history of the Monell Jefferson Clinical Research Collaboration is really seeing patients 3, 4, 5, 6 months after they've lost their sense of smell. And that is actually one of the problems that flavors all of the literature in smell loss, that the interventions for smell loss occur too late. Imagine that someone would have a stroke and that you would see them 3 months after the stroke. So not really much that you can do to help that individual, and you can't really design studies that will show that you're going to help that individual. This is one of the things that really we would like to do, is involve our primary care physicians really in trying to identify patients that potentially have a loss of sense of smell earlier so they can be referred appropriately. Then we can assess the history. We can perform an examination to see if they've lost smell identification or if their thresholds are elevated. And we can do the nasal endoscopy, look at the inside of the nose, and order the appropriate studies. And then hopefully we'll be able to advise the patients on different treatments. Because of the difficulty in doing the research, these treatments are few and far between. But there are some things that patients need to do who have lost their sense of smell, even apart from treatment. And I'd like, Beverly, maybe for you to talk about some of the lifestyle changes that anosmic patients must make.
Well, the most obvious thing is they more than anybody else are in need of smoke detectors. So they should probably have more in their homes than most people do. Many people who have gas in their home are not aware of the fact that there are home gas detectors available. You can just look on Amazon and find them. But if they have gas in their home, that's a real problem because they can't smell the leak. They need to label and date foods that they store so they know when they need to throw them out, since they can't smell spoilage. And the final thing, which a lot of people overlook, is that when they're working with strong chemicals, pesticides, paints and solvents, cleaners, they need to be sure they're in a ventilated area or that there are others present. We've had a number of patients come in over the years who've had major accidents using like pesticides in their home, not being aware of how much they had actually sprayed because they couldn't smell it. And having somebody come home and have to drag them out because we're slowly poisoning themselves. So those are some of the main issues that people have to be aware of.